compliments of the new year to our audience. Welcome to the first briefing of 2026 from Africa CDC. My name is Margaret, Edwin, the Director of Communications. I'll be moderating this session. Today we are joined by Professor Yap Boom, the Deputy Incident Manager from the Incident Management Support Team, with the briefing touching on health emergencies across the continent. I will now hand over the floor to Prof to start the session. Over to you, Prof.
Thank you so much, Meg, and it's really a pleasure to start the year with all of you. Wish you all a happy New Year 2026 to all of you, our journalists, but also to all the colleagues, all the partners who have been following us for more than a year now. So to you and your family, we wish you a very happy New Year. So today we will go to, as we did last year, to the challenge, the opportunity that we've seen on how we are handling those outbreaks and epidemics in the continents. Over to you, Margaret. Okay, so I'm going to go through the health emergency in the continent on behalf of our Director General, His Excellency Dr. Jean Casseya, who is currently in Geneva, as I will mention over the presentation, and who was not able to take the call. Next slide. So the year has ended, and actually 2026 have started with those recognition of Dr. Jean Casseya as the right person at the right time, bringing the change, the transformation of the global health. You've been following the new vision of Africa CDC to advance Africa health security and sovereignty agenda. And one of the key pillars, the first one actually, is the transformation of the global health architectures. So moving that forward over the year 2025 has brought those recognition by the New African as one of the most influential African, but also one of the most reputable African. And from our DJ, it's really an appreciation, but more importantly, the need to share a vision with humility and purpose. And as he has highlighted, is also an appreciation not only to him as an individual, but to the entire colleagues of Africa CDC, the AU member state, but also the partners who are working all together with Africa CDC to protect the health, but also to strengthen the preparedness across Africa. Next slide. So as an opportunity also to wind up the year 2025, we have that end of year review where there was also many opportunities. One, to appreciate all the work that has been done in 2025, comparing to the previous year, tremendous improvement has been achieved. We can emphasize the due diligence that Africa CDC went through, but also the appreciation that now we are an entity that not only is able to push in the operation in the field, responding to the outbreaks, the local manufacturing and many of those ones, but also the ability to manage fund through the appreciation that we get with the UK government. That has also led us to become one of the key partners who can really push this new vision. So, and it was also the opportunity to appreciate Dr. Yenyu, who is currently the director of the laboratory division, and Dr. Wissam Mankula, who is the Northern Africa Regional Coordinating Center, as the two people that were the most outstanding in the year 2025. That also linked to the appreciation, the recognition of Dr. Casseya, that rely on an entire team that you've seen in one of those pictures on the left side. Next slide. So as mentioned earlier, there is numbers of engagement that the Africa CDC leadership is currently having in Switzerland and also in Brussels. It has started by the meeting with the Excellency Guillermo Amente at the African Union Permanent Mission, but also many other stakeholders that are based in Geneva, including the WHO amongst the institution that will be met by our DG and the leadership over the week. Next slide. This is really to emphasize the African leads and multilateral organization support, where we see the continental institutions, just as Africa CDC, but here, more importantly, the African Development Bank. And it was an opportunity by our DG to congratulate the President Sidi Oulta for replenishment of 11 billion historic funds. So that represents 23% increase from the previous replenishment. And we are really proud, not only as the DJ, but as Africa CDC, to see African countries stepping forward to drive the continent's future. And as you remember, the domestic financing is one of the key pillars of the new vision of Africa's security, but more importantly, sovereignty. So this is really mark a new era of African investment-led development. And AFDB will be a key partner in many countries, including Africa CDC as a regional entity, moving forward with the pandemic fund that has been received by many countries, but also by Africa CDC. Next slide. So our DJ has also met Hermann Grohe, who is the president of the German Red Cross and former German Health Minister. So the meeting aimed to strengthen, excuse me, just one second. The meeting aimed to strengthen the global health architecture, to reinforce the national ownership, but also to advance the preparedness and antimicrobial resistant effort in the continent. This was as well an opportunity to really strengthen the partnerships that are critical. As we mentioned, we want Africa to lead, but also we want the global to keep on supporting. And this is one of the areas where we are working to that support to make a change in the continent. Next slide. We were also happy to receive the visit of the International Vaccine Institute, IVI, with the Director General, Jerome King, with the leadership to push the agenda of African manufacturing as vaccine is concerned. That includes not only the manufacturing, but also all the clinical research, starting from the clinical trial to the phase 1, 2, and 3, to ensure that we have optimum and efficient way of delivering the vaccine in the continent, remembering that 98% of the vaccine used in the continent are actually imported in Africa. So there's an opportunity to see all together how we can bring that change. And also an opportunity to emphasize the need for this partnership to reinforce the African vaccine ecosystem and enhance preparedness for future health threat and sovereignty. Next slide. So now looking at the different events in the continent, here we'll take advantage of emphasizing the heterogeneity of the events in the different regions of Africa. As you will clearly see, we have the Western Africa that is really highlighting the most important number of events with 77, with 14 of the 17 member states being affected. The top 3 are Mpox, Lassa fever, and measles. This morning we were discussing with our regional coordinator for West Africa, emphasizing the challenge of Lassa fever currently, where 97% of the cases are really affecting Nigeria, and there is a critical need to bring that support. In other countries, you will see that measles is one of the diseases that is cutting across the different regions, similar as cholera, which is present apart from the northern parts, and which will come later. We have diphtheria that we are also seeing in numbers of our region, which is also an opportunity to think how the MSC that has been used for Mpox, which was going across the continent, can be also benefit from a coordination or a collaboration platform, which has been leading the response to Mpox and now to cholera in the continent. Next slide. Now, going to the issue of Marburg virus disease in Ethiopia. Now, we are currently in the countdown where we are looking at 42 days before declaring the outbreak over. So there has not been any case seen, confirmed for the last few weeks. And then we remain with 14 days to declare the outbreak over. So this is also an impressive example of leadership on how to respond to this outbreak, how to control it at the source, at the level of Jinka and Awasa, without having other cases surrounding beyond those districts. Next slide. Now, this platform starts with Mpox. So it's important to pause to see what has happened between 2024, 2025 as Mpox is concerned. As you can see with the yellow curve, you see the increase in the number of cases that was continuing toward the year. And then in 2025, we had the peak at the continental level that happened in the month of May with more than 6,000 cases within the month, and going down lower than 100 cases at the end of December. And you can see in terms of region, the central region of the continent has been the most affected, whether we are looking at the number of cases or the number of deaths. This is also due to the DRC that was really representing the large majority of the number of deaths and the number of cases. Next slide. Yes, this one. So as you can see the evolution, the curve, you have that normal curve where we are really seeing the end of the curve is the first one on the top, which has the confirmed case going really down, which means that we are reaching a stage where we are more confident on moving toward toward the end of this outbreak, but not toward the end of Mpox, as you will see with some new cases coming in some countries. So what is important also to highlight is the fact that we have doubled the number of cases between 2024 and 2025. As you can see, 211% increase in the number of cases, but also in the number of deaths, it has been multiplied by more than 5 times. But as we do speak now, we still have Mpox in many countries, DRC, Guinea, Liberia, Kenya, Ghana, Uganda, a bit of Burundi and Nigeria. And those countries account for 90% of all confirmed cases. So, but where we are also glad is to see the 91% decline from the months of May, June, when we had a peak, up to the end of the year in December 2025. Next slide. Now, this is an important slide because in this slide, you can see that most of the countries, almost all of them, are seeing the decrease. Quite a number of them have been having 0 cases for the last 3 weeks, Sierra Leone, Togo, Mozambique, numbers of them, while we have Mali that have seen an increased number of cases, but we still remain within 11 total confirmed cases, which is quite low. And South Africa, it is low, but it's important to remember that all the outbreaks start with 1 case. So it's important, though we are seeing the decreasing in most of the cases, to really support the country that are either seeing new cases, as we see later with Madagascar, or countries that are seeing a resurgence of cases, as we will see later with Mali and also Cameroon. So it's an important decrease in most of the country, highlighting the improvement in control, but also, it's critical to assess and ensure that the data that we are showing reflect the reality. That's what we continue to monitor the country as we move toward bringing the Mpox within the routine and moving toward its elimination. Next slide. Now, in Madagascar, this is the one that one of the new countries that has been highlighted having some cases. So far we have 136 suspected cases. 18 has been confirmed so far. 0 0 death and 1 affected region. Actually, now we are moving toward 2 regions that has been affected. So initially, the location was Majanga, which is a urban commune. So we've been engaging the country from the initial, the emergency operation center has been activated, and the leadership is quite present, which is one of the success, the key driver, you remember, for the successful and efficient response to Mpox. The first one is the leadership. And then we are glad to see that in Madagascar, the outbreak is managed at the level of the Prime Minister to ensure that there is a multi-sectorial approach, to ensure that we have all the different bodies that are critical in the response. So far, they have those 18 confirmed cases, and they are implementing and strengthening the surveillance, but also moving towards the admission of all the patients to ensure that they stop the transmission. But around Madagascar, we also have Comoros who that currently have no case, but who are in the preparedness phase. So even yesterday and this morning, we were engaging the leadership of the Ministry of Health, who also is making sure that they are prepared. There is a mission with the Minister of Health and the Secretary General and other colleagues moving in the island of Anjouan to ensure that everything is in place. Why Anjouan is because that is one of the islands where we have an important mobility from Madagascar to Comoros. And we have 1 case in Mayotte. Though Mayotte is a French territory, there is also some engagement to ensure that they receive efficient and adequate support to avoid seeing the increase in the number of cases. Next slide. In Liberia, where we have been supporting with the colleague from the IMST, and more importantly, with the colleague from Sierra Leone. So this is that South-South collaboration and that cross-border collaboration where we had the colleague from Sierra Leone that have successfully responded to the Mpox using one of their flagship point of the response, which was the Operation Find Them All. This is the integrated community-based response where we have the surveillance, active surveillance, where we have the risk communication and community engagement, but also where we are leveraging the vaccination as one of the key pillars. So bringing that experience from Sierra Leone, moving it to Liberia, we are yet to see the improvement. As you can see already, the test positivity rate has really decreased from 80 to almost 90% at some point. Now we are down to between 17 and 33%, which is a good sign that the patients that are tested positive are actually those that we capture in the community. So that's a very good indicator of strengthening that community-based surveillance. Next slide. In Kenya as well, the same kind of support has been brought under the IMST, also strengthening the intensification of the community-based surveillance. And as you see also here, the test positivity rate has really declined, moving from 62, 70% to 40 and 17%, also giving confidence on the trust, the community-based surveillance being quite critical. So the 10,000 doses of vaccine that were received a while ago and all used in Kenya has been exhausted. So they received 20,000 doses that they will be using starting, I think, the 1st February to ensure that they can also now move in those key places, Mombasa, Busia, and Nairobi, that together account for more than almost 70% of the total confirmed case. So this is also important to reassure all of us that though Mpox is still there, the countries with some support have the capacity now to implement what is critical to control the Mpox within the countries. Next slide. In terms of vaccination, I think that's also one of the key pillars we want to highlight. More than a year ago, in August 2024, when the declaration of the facts were done by our General Director, the number of those that was expected were around 20,000 for the whole continent. So now, over the year, with the strong support of our different partners, with the advocacy, we've managed to mobilize 6 million doses, and 5 million has been delivered to 16 countries. Part of it, 3 million, went directly to DRC through the bilateral partnership with the government of Japan. So we had 18 countries that are granted the regulatory approval for the MVABN, and also 2 countries that consider persons under 12, because we know that the children also between 1 and 17 account for 30% of the total person vaccinated in the continent, because they are also exposed. And in some countries, they are also the most vulnerable. So to date, above 2 million doses has been administered, 1.2 MVABN, and almost 800,000 of LC16, and that is for DSC. So currently, there are some engagement with different countries. Madagascar, that I mentioned, with that is having the new case. Cameroon, that is also showing some resurgence of new case in the littoral, in Douala, more specifically, with a clade that is most likely different to the zoonotic clade that they used to have. The sequencing will be ongoing, and then we'll have the exact clade. So there are also some discussion on supporting them, as well as Mali, to move forward to acquire some vaccine. We appreciate that the vaccination is not a silver bullet, as we did see in Burundi, but also it's an important pillar that can also help to fast track the control of Mpox in many countries. Next slide. Now, moving to cholera in the continent. So we ended the year 2025 with that outstanding numbers of 323,307 cases of cholera. We also have 7,352 deaths amongst the confirmed cases, with 24 member states that has been affected. So when we look at those data and we compare them to the other disease, Mpox, which we had 300 deaths, and then even measles and others, definitely cholera in terms of case, in terms of death, is definitely the major challenge that the continent is currently facing. And our role at this point and for this year is really to push for innovative way to address cholera in the continent. As you will see in the different countries, we definitely need to move faster on bringing other sectors, the ministries of water and sanitation, the ministries of finance, the ministries of planification, all those other ministries that have a significant impact on access to water are the ones that are the most critical to ensure that we reduce the burden of cholera, not only for a few months, not only for a few years, but really to have a sustainable reduction, moving toward cholera elimination by 2030, which is part of the global agenda. So now we have some new case that has been reported for Malawi, and we will see that South Sudan, DRC, Angola, and Nigeria contribute for almost 90% of all the cases in 2025. But we were glad to see that Chad has also officially declared the end of its outbreak, and next week they will be having the intra-action review, which is the time to pause and to ask the question, what went well? What have they done well? That lesson learned that can now feed the continental incident action review, and then to support other countries on the lesson learned in Chad. Next slide. Now, when we look at the evolution of cholera over the year, we've been seeing a trend where toward the end of the year, October, November, December, we were seeing that increase. that most of the time is also connected to the increase in the flooding in the rainy season in many countries. But for this year, 2025, gladly, we are happy to see that in many countries, I've just mentioned Chad, but many other countries, there has been a decrease on the cholera number of cases and the number of deaths. Though the eastern region of the continent has been the one having the bulk on the number of cases, but also the number of deaths, we can see that the Central African region has been the highest in terms of case fatality rates. And regardless of the region, we've seen that the drivers are the same, the access to clean water. So the poor wash activities, but also the cross-border spread. We were discussing this morning with Mozambique, which is also affected by the neighboring country. We've been discussing this morning as well with Burundi, which is affected by the refugee coming from DRC, and also bringing in those refugee camps, you have a better opportunity for cholera to spread. So looking at the long term, definitely the wash infrastructure are critical, but also the improvement of how we manage those outbreaks in the humanitarian setting. Next slide. Now, looking at the two countries that I have just mentioned, Mozambique and Burundi, those are the countries that were presenting as our weekly meeting that we have with all our member states affected by either cholera or Mpox, having that discussion, that time to share experience on how we are responding to one or the other. So definitely, Mozambique has been showing the increase in the number of cases, but also how they are managing the outbreak in their country. And they've highlighted one of the challenges in which you, as a journalist, can contribute on how to educate the community, how to ensure that we can address the issue of misinformation by providing the right information in terms of how to prevent cholera, but also the political advocacy so that the cholera is not managed only at the level of the Ministry of Health, but really at the highest level to ensure that all the different sectors are engaged. This is the same thing that we'll be seeing with Burundi with a multi-sectorial approach. But we can, as you can see, DRC, there is a decrease, but it remains with the bulk number of cases and deaths that we'll be seeing a bit later. Next slide. Now, going to Burundi that we've just mentioned, as Africa CDC and IMST, we have been supporting on strengthening the multi-sectorial engagement to control cholera, which means bringing other partners, not only to provide the hydrated solution in the community, but critically engaging on the production of the pothole and pushing, ensuring that, as I mentioned today, the Ministry of Water and Sanitation is really pushing to increase the water access in many places of Bujumbura. That is the capital, but where the extension of the city has not been at the same time of the extension of the water and sanitation infrastructure. So that is being considered to ensure that this is being addressed. Now, Burundi is also affected by the influx of refugees who are coming from DRC, and this increased the risk of cholera that has been seen in the refugee camp. So now, in terms of support, we have the mid to long term, the building of those infrastructure which is happening, but also the push for the vaccination. So there is what we call the preventive vaccination that is being planned, where they will be able to use the 2 doses of the vaccine in some places, but also now it's critical in those refugee camps to have access to vaccine and to vaccinate those populations. So we are supporting the country for the demand of vaccine that will be submitted today, and hopefully we can fast track so that they can really implement the vaccination campaign in the upcoming days or weeks. Next slide. As mentioned, Mozambique also did present the cholera situation today, highlighting that in most of the districts, less than 50% of the population have access to clean water. Also highlighting that, especially for children, the challenge of open defecation is one of the key drivers to bring the cholera. And as you see, there have been a first wave early 2025, and now this second wave is increasing, though we can see some slight decrease. And critical in the country is one, already mentioned, the communication and the community engagement, which is critical, but also as for all those countries, the emphasis of building strong infrastructure that can last and ensure that cholera is being eliminated by 2030. Next slide. Angola is a case study, as we want to believe, a good example of how the medical countermeasure, the medical response to cholera can really address the outbreaks. But however, it can address it not in a sustainable manner. Seeing the two peaks within the same year, it's also an evidence that, yes, we can provide a vaccine, we can implement the WASH to respond to the outbreak, but that second wave that happened in some districts that have not been vaccinated is also a call to, one, appreciate the increased production of vaccine, but saying that we need more of those vaccines so that in places that are surrounding the place where there have been some cases, we need to ensure that we increase the preventive vaccination, which is 2 doses, as compared to 1 dose in the reactive one. So we need more vaccine available, but also we need in-country, and that's something that we'll be supporting with the task force to ensure that we have a more limited zone, hotspot, defined in each country where it's critical to have access to water, but also to those to implement those preventive vaccination. Because at this point, it will be hard for most of the countries to really, at the same time, put the infrastructure everywhere. It's critical to identify those critical districts where, at this point, the WASH need to be implemented, but also the preventive vaccination to allow the country to keep with time building the infrastructure to ensure that we reach our target of elimination of cholera by 2030. Next slide. So in summary, the Marburg virus disease, we are counting down the case in Ethiopia. So we still have 14 days toward the declaration. At the same time, it's an opportunity to strengthen the surveillance, to build a system, not only in Jinka or around Jinka, but also in the surrounding district. This is one of the support that we are also bringing to Ethiopia to ensure that other districts, other regions are also equipped, because we don't know where and when the MVD can also happen. We have the South Sudan. We have not mentioned it in this outbreak, but in this presentation, but last December, we mentioned that in Sudan, there has been some report of suspected cases. So we are still doing the investigation with the country, but so far, there is no case that has been highlighted. So as Mpox is concerned, we got the recommendation for the ECG, but we are yet to get the official response of our Director General on how we move toward the transition of Mpox in the routine. So that will also be an opportunity to move forward with the roadmap, bringing Mpox in the routine, but in the meantime, to prioritize the support to high burden and vulnerable countries. So an opportunity to preserve the gain that have been done during the year, but specifically the IMST coordination, but also all the lab decentralization, the risk communication, and all the gain that now can be translated to other diseases such as cholera, where we've seen a significant decrease toward the end of the year, but needs to accelerate the support in DRC, Burundi, Nigeria, Angola, and many others. So as the year is starting, is really the opportunity for us, for you also, to see how we can innovate, really innovate on how we respond to cholera, to Mpox, and other disease, how we can reach beyond the operational, the strategic, and the more engagement at the political level, because that's where the most critical decision are taken. That will allow us for cholera to have more vaccine for the preventive vaccination, and also to ensure that we can keep on pushing the agenda of local production. So we've been a bit longer today, but I think it was important to really go through the feedback from next year, but also to give some perspective of how we are seeing this new year. So now at this point, I go back to you, Dr. Margaret, and happy to take some questions for our dear journalists. Over to you.
Thank you very much, Prof. Let's cross over to the floor. We have Gabriel Emmanuel from NPR. Gabriel, you have the floor.
Hi, thank you so much for doing this as always. I wanted to ask actually about something that wasn't mentioned yet in your presentation, but about a study into Hep B that's happening in Guinea-Bissau, or it's supposed to start early this year. It's not looking at the effectiveness of the vaccine, but it's looking at the other effects it might have. And I just wanted to see if Africa CDC has a stance on this study that's partly funded by the CDC in the US, and if so, what it is. The other question I had quickly is that you mentioned misinformation around cholera, and I wanted to see if you could elaborate on kind of what information is flowing. Thank you so much.
Thank you very much. Let's take the next one before Prof comes in. We have Melody from The Guardian UK. Melody, you have the floor.
Thank you so much. I also had questions about the Guinea-Bissau hepatitis B trial. Did it start? Is it going to happen? Thank you.
Thank you very much. Prof, back to you.
No, thank you so much, Gabriel and Melody, to the question. So this study on the hepatitis B was meant to happen in Guinea-Bissau, and which raised some critical challenge on the ethical, the way the study was designed, and which was a big challenge. So since we got the information, the colleagues from Africa CDC, especially the Professor Mosoka, who is leading the Research, Science and Innovation Directorate, has really informed us to see what was the best way to move forward. So there has been some engagement with the leadership of Guinea-Bissau, but since then, the information we received is that the study has been cancelled. I think that's also an opportunity to review at the level the design, because it's important. We need research, definitely. We need to be able to assess the efficacy, the effectiveness of different vaccines. Hepatitis B, it's one of the critical diseases in the continent. So definitely, it's of importance for Africa CDC to have those evidence that can be translated in policy. But this has to be done within the norm. So we are glad that at this point, the study is being cancelled, and there will certainly be more engagement with the leadership in Guinea, but also in the US, to see what is the best way to implement such study to also gather evidence that are critically needed. So in terms of cholera misinformation, it's really depend on countries. In some countries, because they see the connection with rain, they believe that it's also a punishment from the god that happened out during the rainy season. I was even getting some feedback that in some countries they believe that it's because some of the community member will go when there is a rainbow, and when they will go there, they will get contaminated. So there are a couple of those misinformation that come from the fact that we have not successfully managed to reach the community and provide the right information in one hand. In the other hand, beyond the misinformation, the critical thing is access to water. If 30 to 40% of the population, if not more, don't have access to clean water, regardless of the information that they have, they still need to have water to drink and for many other things. That's why we really emphasize as one of the critical ways to support the response to cholera, to really reach the highest political level, so that the building of infrastructure in water has a long and sustainable impact in those countries.
Great. Let's take the next two questions. We have Rachel Abuja from the Nigerian News Agency. Rachel, you have the floor.
Good afternoon, everyone.
Good afternoon. Welcome.
And Happy New Year. So, Prof, given the recent decline in Ebola and Marburg cases. How can West Africa countries sustain surveillance and preparedness to prevent future outbreaks? And with preventive vaccines, wash infrastructure, and community engagement, which is all critical, as you've said, how can countries prioritize and sustain these efforts in hotspot areas to achieve long-term elimination of cholera and other pandemic-prone diseases by 2030? Thank you very much, and over.
Thank you. Back to you, Prof.
Yes, thank you, Rachel, for the wish for the new year. No, you are right, and Nigeria is one of the most affected countries by cholera, but also we've mentioned earlier by Lassa fever. So the way we are looking at it, we consider that each outbreak must be an opportunity to strengthen the system. So while we are going out of the Ebola, the MVD, but also the Mpox, we believe that, as we've seen in many countries, the lab decentralization, the intensification of the community-based surveillance will be some lasting tool that the country will be using. Now, the second thing is the strengthening of the National Public Health Agency. As you recall, for each outbreak, you will have one new committee that will run. Now that we have those strong agency, and I think Nigeria is a very good example of a country that have a very strong NPHI, they will keep on building on the strengthening the surveillance system and so on to ensure that whether we are talking about Ebola, cholera, MVD, they have that in place. Now, specifically for cholera, you mentioned the issue of preventive vaccination. We appreciate that the dose of vaccine in terms of pollution has been increased. So now we definitely need more to ensure that in the endemic region, we have more of those preventive vaccinations. That is one. But more critically, we need to, as much as possible, narrow down the hotspot. Because if the hotspots are too big and too numerous, it will be difficult. We need a better exercise of prioritization in Nigeria and in many other countries. This is something that we'll be working together with the GTFCC, the colleagues that are more on the side of preparedness, to ensure that we do the exercise, and on one side we have a smaller number of zones that we need to target that can match with those that are available for preventive vaccination, because as you know now, having 2 doses of vaccine will bring a protection for 5 years, while only 1 dose can bring a protection for only 1 year. Now, the other point is really the WASH, the infrastructure, whether it's in Nigeria and others. This is one of the key things that we really need to push at the highest political level. And we believe that the upcoming African Union Summit that will happen in the second week of February in Equatorial Guinea will be an opportunity to bring cholera to the attention of our leaders, as they did last year, to really see now how can we mobilize more resources for the continental plan and support countries like Nigeria and others to have long-lasting solutions.
Let's take the next 2 questions. We have Kumba from Gambia Daily. Kumba, you have the floor.
Thank you, and good afternoon, everyone. I'll go straight to my questions, although I have multiple questions here. I don't know if time permits me. My first question is, given recent confirmed outbreaks of Marburg virus disease in Ethiopia with high fertility rates and the ongoing Ebola activity in Central Africa, how is Africa CDC strengthening cross-border surveillance and rapid response activities to detect and contain viral hemorrhagic fevers before they spread to neighboring countries? My other question is about cholera. With Africa facing what has been described as the worst cholera outbreak in 25 years, how is Africa CDC coordinating with member states to enhance water, sanitation, and hygiene infrastructure? And what measurable impact do you expect these interventions to have within the next 6 months in this new year? And also, despite global progress in immunizations, millions of African children still lack access to life-saving vaccines. What concrete step is Africa CDC taking to accelerate vaccine delivery and local vaccine production? And how will success be measured? Thank you.
Thank you. Back to you, Prof.
As she mentioned, those are very many questions at the same time. Thank you so much, Kumba, for all those very insightful questions. The first one on, you mentioned the EVD in Ethiopia, the Ebola in Central Africa, and so on. How are we preparing the neighboring country? So, and I will also add even Mpox, because what you are highlighting is the key component, which is preparedness. So since, for example, there have been some cases in Ethiopia, there have been some engagement with South Sudan, but also with Somalia, with Kenya, to ensure that there is that sharing of information on one side, but also assessing their capacities. That's also how in South Sudan they were able to detect in the community the three suspected cases that has happened, and now they keep on following the investigation. They have the EOC that has been activated, so we support into that. But more systematically, as you know, the IMST is a response platform. Now, the conversation that we'll be having early February when we'll do our IMST review is how to integrate at the continental level the preparedness so that we have that coordination, that collaboration within the different organizations and partners to ensure that the preparedness and the response talk to each other, and then we have countries that are better prepared in terms of infrastructure through the NPHI and the COOS, but also in terms of training and also definitely in terms of the capacity to respond whenever they have a case. Now, as cholera specifically is concerned, you mentioned how we are supporting member states in terms of the WASH, in terms of the response. We have many ways. The first one that we do have is engaging with the member state. Every Thursday, like we have this meeting in the morning, we have a meeting with all our member states, and they present the way they prepare or the way they respond to cholera or to Mpox. This is one opportunity to share the information, to share all the tools that they need either to prepare or to respond. The second thing is we will be having, once again, early February, our intra-action review. Going backwards, we launched the Continental Cholera Plan that was in Lusaka by the AU champion, the president of Zambia, His Excellency Ichilema. And since then, a number of things has been happening. In many countries, we've been the support mission, we've been some vaccination. And as you see, the cases have been going down. So there are some good things that has been done, but also there are some things that need to be improved. So those few questions, together with the MST partners and the member states affected by cholera, will pause and see now, what should we do differently? And those discussions will now feed the AU summit that will happen 1 week or 2 weeks later in terms of how at the highest political level, we can now address the issue of cholera, moving toward the long-lasting elimination of cholera by 2030. Now, the last question on the life-saving vaccine. You are right, 90% of our vaccines are still imported. We've been pushing for the local manufacturing, and then we have countries like Algeria, where more than 70% of the medical countermeasures are produced locally, which means it is possible, but also to really push, once again, at the political level, this agenda. In April, there will be an extraordinary summit that will be led by the head of state of Kenya on that specific issue of local manufacturing. So this will bring not only cholera and so on, but how can we push that agenda for vaccine, for diagnostics, but also for rapid diagnostic tests. So it will be the time where we push at that level and we go out of that with some very critical solution. So yes, it's something that is critical, but we need action. This action has to happen at the highest level.
So let's take the next question. We have Stephanie from New York Times. Stephanie, you have the floor.
Thanks so much, Margaret, and good morning, everyone. Prof, I'm wondering if you could say a bit more about this Guinea-Bissau hepatitis B trial. I'm sorry to drag you back onto this topic, but I had heard last week that the trial had been canceled from a number of people who seemed to be in a position to know, but then Over the last 2 days, I've spoken with a number of senior figures in the Ministry of Health in Guinea-Bissau and with their ethics review board, and with folks who are meant to be doing the actual implementation of the trial. And they tell me that it is very much still ongoing and that it has not in any way been canceled. And I'm trying to reconcile the position of the Africa CDC and others that it seems to be canceled. So could you say a bit more about why it is you believe that it's canceled, how recently you were told that, and who told you? Because as I said, senior people in the ministry are telling the New York Times, at least, that it's very much ongoing.
So the information that we have is that the study has been cancelled, though, as you rightly mentioned, there are still some conversation happening because, as I mentioned once again, the research on the hepatitis, which is the critical disease in the continent, is needed. So now, as Africa CDC, that's a question we are asking us, what has been done? So at our leadership level, we have also prepared a team which has been having some engagement with the Ministry of Health. And depending on how it goes, we will have a visit in the country to also ensure that, as we do for all member states, they receive the adequate support to ensure that this study, if it has to happen, will also fit the ethical regulation. This is what is critical. Now, what was the person who actually sent the information that has been cancelled? I don't have that information, but I think the most important thing is that we want to move forward to support the member state to continue the research that is critical for the continent, but within the ethical role, because that is the most important to protect our community as research is concerned.
Great. Let's take the next two questions. We have one here from Michael Guarisa from the Health Times in Zimbabwe. The question is, during the Cervical Cancer Awareness Month, how prepared is Africa to tackle cervical cancer, particularly in terms of treatment capacity, such as radiotherapy equipment? From Africa CDC's mapping, is the region adequately equipped, and what support is being provided to member states to address identified gaps? Back to you, Prof.
Yes, thank you. I think that's a very critical question. So the cervical cancer, it's one of what we call one of the silent killers, because unfortunately in the continent, the diagnostic of cervical cancer, it's really low. We have countries like South and many others where the first large mass campaign for screening has happened within the last 3 to 4 years, which is highlighting that what we see is actually far from what is actually happening. That's why these months of awareness is critical for Africa CDC. This is managed at the level of our primary care center, because this kind of disease and management has to happen within the community. So it's also an opportunity for us to re-engage our community healthcare workers, who are the ones who are every day in contact of the community, to engage in that awareness, bringing the right information, because the awareness is first. And the large majority of women in our continent don't have access to the service of the gynecologist because they are not there. So now we need to be more innovative on how we can provide information, but more critically, how we can decentralize the screening. And this decentralization of the screening will not happen with the specialists because they are not there, but with strengthening the system with the nurse that could be in some at the lowest level. So we are discussing all those innovative ways that are contextualized in countries to ensure that, one, we raise the awareness in the community with our community healthcare workers, but also with the risk communication and community engagement. So those are the key pillars that within our primary healthcare center we are going to support the months. Maybe Director Margaret, if you want to say some few things on the communication on that, maybe I can hand it over to you.
Thank you very much, Prof. As always, Africa CDC usually comes up with a campaign that aims to share and sensitize the public on the public messaging around cervical cancer, and that is in progress, and we will be in touch in regards to that aspect. So I'll move on now to the next question. We have Ines Vala, from the senior healthcare reporter from APM Market Access. And the question is, you mentioned that more than 6 million doses have been delivered but only around 2 million administered so far. What is driving the gap between delivery and uptake, and are there specific countries where rollout is stalled due to regulatory, logistical, or demand side barriers? That is the first question. The second question is on, you referred to awaiting the Director General's decision on transitioning Mpox vaccination from emergency use into routine immunization. When do you expect that decision, and would this imply sustained procurement commitments from member states? Back to you, Prof.
Yes, thank you so much for the two questions. The first one on the vaccination will be responded by my colleague, Dr. Charles Ibeneme, and I will answer the one on the ECG. So the Emergency Consultative Group, the ECG, that you know now very well, has made their recommendation. And those recommendations has been considered based on the data that we've shown to you, the reduction of the case, but also the fact that the country are much more equipped as we do speak now on responding. I've been talking about Madagascar, who have some case, and then we are supporting them to control at the source. You've seen what had happened in Namibia that has been able to control Mpox with just two confirmed case. So the capacity of country has increased, and therefore they feel that we are more confident on how we respond to Mpox. But in the other hand, they also appreciate that it's not over. The disease is not over, and we need to learn from the past. One of the reasons that has allowed the emergence of Mpox is the fact that we used to have smallpox. And since the vaccination of smallpox has been stopped in the 80s, now it's also open, because there are all the orthopox, it opened the way for Mpox to keep on growing. So the fact that smallpox has been eliminated through vaccination also opened the possibility to increase the herd immunity by providing vaccine, specifically in the endemic countries. We have DRC, we have CAR, we have Cameroon, and so on, where those vaccinations could happen and ensure that we move toward the elimination. But before that, we need country now to transition Mpox into the routine. And this work has been done with the different member states and the IMST partners to have a transitional roadmap. So the document will be launched to ensure that each country which has been having Mpox know how to integrate, but also those who have not been exposed, because remember, only 32 out of the 55 countries on the continent has been reporting Mpox cases. So which means there are still some countries that have not been having Mpox. So those ones also need what to do, and using that roadmap as a guidelines to respond to that. So then to the question of when, most likely by next week, definitely we'll have the decision for our Director General, and then we'll be happy to communicate that to you. Over to Dr. Charles for the question on the vaccination.
Yeah, thank you so very much, Prof, and thank you for that question. I believe you can hear me loud and clear. So the misalignment mainly around the number of doses in terms of utilization and delivery is mainly being driven by the LC16 vaccines, which of course we know about 3,050,000 doses was delivered to DRC alone. So when you put that into the stock, you see that its utilization has not been as optimal as we likely had wanted it to be. And this is mainly due to some constraints, which are borders around logistics and the likes. However, for the MVABN and across countries, what we've seen is more than 50% of countries have actually gone beyond 50% utilization rates. And when we talk about countries like Rwanda, Nigeria, Malawi, Ghana, Mozambique, Sierra Leone, Uganda, all these countries have actually had very, very massive utilization rates. So in a nutshell, what seems to be limiting the consumption is around the LC16. But this is something we are currently working on with the DRC team. As you are aware, of course, they've developed an intensification plan for the expansion of the LC16 vaccine deployment within the country. Hopefully, if this is implemented, we'll see more numbers going up. And there was a question around legislation in terms of authorization So far, we've actually not had issues, delays due to regulatory issues, across countries. As we've seen, most of all the countries where vaccines have been deployed, because having an active EUA is a panacea for vaccines to be deployed to countries in the first place. So that has not been an issue for us so far. Unless for countries that are still coming in, for example, countries like Madagascar and the likes that are just coming in, and we're currently working with the countries to develop their regulatory documentations. Thank you, and back to you, Chair.
Thank you very much.
Thank you.
Yeah, okay. And with that, we have come to the end of the briefing this week. I will hand over the floor back to you, Prof, for your closing remarks.
Thank you so much, Director Margaret. Thank you to all the journalists. It's, as you've seen, it has been a pleasure to have this conversation with you. We believe that this new year is a year where we need to be a bit more efficient, as we've seen all the change. And through your question, you also appreciate that we need to adapt, to adjust, to be more efficient, to do more with less, because the funding have been decreasing, but you've also seen the member state that has been more engaged, and us as Africa CDC in our new vision to push for the domestic funding. So, but this year will be also an opportunity to do different, to innovate, to be bolder on how we can reach our communities, how we can reach our politicians, so that at that level also the decisions are being made to ensure that we have a better access to water for our communities, but also a better access to care and prevent those outbreaks. We've had some questions on cervical cancer, which means that we are not concerned only by the outbreak, but also really by ensuring that our population is safe and also our country are sovereign. But once again, let me take the opportunity to wish you all a happy new year, to all the journalists, to all our colleagues who have been working the entire 2025 and now have taken advantage, some of us, to recharge, so that in this year we can give the best of us for the good of our communities. With that, I say thank you, and go get back to you, Director Margaret.